This is Wound Healing and Management, Part 1. We're going to start with the different classifications for wounds. Depending on the cleanliness of the wound, we can divide wounds into 4 different categories. The first is a clean wound. This is a surgical wound made under aseptic conditions. Surgical incisions are considered wounds. The second is clean contaminated wound. This is a surgical wound that has been contaminated with a minimal amount of contents that has been easily removed. So an example would be some GI contents or respiratory content that has been flushed away, cleaned, and easily removed. Then the wound is closed. Third is a contaminated wound. This is a wound that has heavy contamination of some sort of foreign material, like grass or asphalt. And then fourth is an infected wound. This is a wound that's contaminated with bacteria, it's inflamed, has purulent discharge, it can have varying amounts of dead tissue. Any traumatic or surgical wound can progress to become an infected wound. No matter what the classification of the wound, all wounds will go through the same 4 stages of healing. The more contaminated a wound is, the longer the stages will last. The 4 stages are inflammatory stage, debridement stage, repair stage, and the maturation stage. And again, each of these stages occur in every single wound. The first stage is the inflammatory stage. This stage starts when bleeding starts. Bleeding is important to cleanse the wound of contaminants, but excessive bleeding is a bad thing. So the vessels will vasoconstrict and platelets will form a plug to stop the initial bleeding, which is our initial platelet plug. Inflammation is what occurs next. This is the most important step in the inflammatory stage, hence the name of the stage, the inflammatory stage. Inflammation does 2 very important things. First is chemotaxis. Chemotaxis is a release of chemical mediators that attract white blood cells to the wound. These white blood cells will be involved in the next stage of our healing and are essential to the entire healing cycle. Chemical mediators also increase blood flow and vascular permeability, which allows the white blood cells to be able to infiltrate into that wound. So this inflammation sets the stage for the debridement stage. So chemotaxis has occurred and our white blood cells are arriving at the wound. Neutrophils are our first white blood cell responders. Monocytes are going to come next. And remember that macrophages are a type of monocyte. And as these white blood cells start to phagocytize the debris in the wound, they're going to produce exudate, which is pus, purulence, suppuration, purulent material. Any kind of pus is what is a byproduct of these white blood cells eating up all of the debris in the wound. And the greater the damage and contamination in the wound, the greater the amount of exudate. And also the length of the debridement stage will increase with the amount of contamination and damage. So this is a picture of a pony's rear end, and it was attacked by a dog. And you can see within the large area of the wound, lots of black, dead, necrotic tissue. All of that is going to have to be debrided by those white blood cells, and there will be lots and lots of exudate because there's a lot of contamination in this wound that you're looking at. Although they're the first on the scene, neutrophils are very messy eaters and can actually increase inflammation, causing the healing cycle to kind of get stuck in the inflammation stage of the healing cycle. But soon monocytes are there, they take over for the neutrophils, and they are much tidier eaters and debride without causing excessive inflammation. Monocytes also provide important growth factors for epithelialization, which is the growth of the epithelium, Also growth factors for angiogenesis, which is the growth of vessels, and then growth factors for fibroplasia, which is the formation of fibrous tissue. These growth factors that are produced by the monocytes are going to promote the repair stage. Now, when we're thinking about wound repair, remember that there are different layers to the skin. The deeper layer, the dermis, and the superficial layer, the epidermis. These two layers heal simultaneously, but use different mechanisms to do so. During the repairing stage, healing of the dermis and epidermis will be happening pretty much simultaneously. In the dermis, the healing mechanism is called fibroplasia. During fibroplasia, fibroblasts infiltrate the wound and begin to deposit collagen. At the same time, the dermis is building new blood vessels in the wound. The blood vessels coupled with the collagen network that is being laid out is called granulation tissue. This is the pink healthy tissue that you can see in the top right-hand corner picture. The epidermis healing mechanism is called epithelialization. During epithelialization, the basal cell layer of the epidermis begins to multiply and the epithelium begins to grow inward, covering over the wound. This growth inward can only happen over granulation tissue. In large open wounds, like the one in the top right-hand corner, it might take several weeks for epithelium to cover the wound. The new epithelial layer remains thin and fragile. It's very prone to trauma, so it has to be protected against self-trauma caused by the animal. As epithelial cells are multiplying, they're releasing something called collagenase, which is what dissolves the fibrin attachments and excess scab so that it can fall off. And then as epithelialization is happening, nerve endings are being stimulated and possibly being regenerated, which is what causes the itchiness you feel when a wound is healing. Pruritus usually starts within 48 hours after the wound has occurred. Peak repair is happening in a wound from about day 5 to day 21. This is when the highest number of fibroblasts are present at the repair site. The debridement stage and repair stage all occur under the scab if there is one. A scab is protection. It's like a band-aid over top of the wound. It helps maintain optimal temperature, it helps maintain optimal moisture, and it protects from contamination and physical trauma. If the wound is too large and therefore there is no scab, then we need to protect the wound with dressings or bandages to provide the optimal environment for that healing, just like a scab would. This is a video that shows the different stages of healing. It shows it in a human hand, but the stages of healing are the same.
The primary objective of the healing process is to fill the gap created by tissue destruction and restore the structural continuity of the injured part. Wound healing is commonly divided into 3 phases, beginning with the inflammatory phase. Inflammation aims primarily at removing the injury-causing agent and limiting the extent of tissue damage as it prepares the wound environment for healing. Inflammation is manifested by redness, swelling, heat, pain, and loss of function. The phase begins with arterioles and venules near the site of injury constricting briefly. Then the vessels dilate, promoting congestion. An accompanying increase in capillary permeability leads to the movement of fluid into the affected tissue. Increasing viscosity causes the blood to flow more slowly, and clotting occurs. Phagocytic white blood cells, or leukocytes, emigrate through the vessel walls into the inflamed tissue, where the leukocytes engulf and degrade the bacteria and cellular debris in a process called phagocytosis. Phagocytosis is part of the immune mechanism to prevent an infection that would impair wound healing. Subsequently, the release of growth factors leads to the attraction of fibroblasts. The arrival of fibroblasts marks the beginning of the second phase of wound healing, the proliferative phase. During the proliferative phase, the focus moves to the building of new tissue to fill the wound space. Fibroblasts are connective tissue cells that synthesize and secrete collagen. They also secrete growth factors that induce the growth of blood vessels through a process called angiogenesis, while promoting endothelial cell proliferation and migration. The fibroblast and endothelial cells form granulation tissue that serves as the foundation for scar tissue development. Granulation tissue contains newly developed capillary buds. The tissue is soft and pink, and because it is fragile, granulation tissue bleeds easily. The newly formed blood vessels are leaky and allow plasma proteins and white blood cells to leak into the tissues. The final component of the proliferative stage is epithelialization, which is the regeneration, migration, proliferation, and differentiation of epithelial cells at the wound's edge to form a new surface area similar to that destroyed by the injury. By the end of the proliferative stage, white blood cells leave the wound site, edema diminishes, and the wound begins to blanch as the small blood vessels become thrombosed and degenerate. The third phase of wound healing is the remodeling phase. It begins after about 3 weeks and can continue for 6 months or longer. During this stage, final scar tissue is being formed by simultaneous synthesis and lysis of collagen. Clinically, the scar becomes avascular. Scar tissue may achieve 70 to 80% of tensile strength by the end of 3 months. Wound healing consists of filling the gap created by tissue destruction, followed by restoration of the structural continuity of the injured part through 3 phases of healing: the inflammatory phase, the proliferative phase, and the remodeling phase.
Although the video only had 3 stages in its healing cycle and the vocabulary was slightly different, it gives you a good idea of how that healing cycle works. Now, the 4th stage in our healing cycle is the maturation stage. This stage occurs from 60 days post-wounding for about a year. And at around day 21, fibroblasts begin to leave the area, leaving only a small number behind. And at about day 60, the number of fibroblasts is at a level that the scar will start to mature. The fibroblasts that are left behind are going to start to contract and remodel the wound to create a smaller, thinner scar. Mature scars are about 15 to 20% weaker than normal skin. This is due to the fact that the body cannot replace elastin once it's lost in the skin, which is what gives it the flexibility and resilience of healthy skin. The healing cycle can be affected by a number of factors. We talked recently about contamination, prolonging it. Different medications can also prolong the cycle. Corticosteroids, for example, have a significant impact on healing. Now, this can be pharmaceutical corticosteroids such as depomedrol, dexamethasone, prednisone that you see in the picture, but it can also be the steroid cortisol that's released by your body when it's having a stress response. Any form of corticosteroid can reduce inflammation, which sometimes is good if the inflammation is excessive, but it will in turn decrease chemotaxis of the white blood cells. Steroids will also cause margination of neutrophils, which inhibits them from actually being able to leave the blood vessels and infiltrate the wound. And then finally, steroids can reduce cellular activity, especially in epithelial cells, which then will affect our repair stage of healing. We have 2 different abnormal wound maturation scenarios that I want you to be familiar with. The first is called a keloid. So if we introduce stress to a maturing scar in the form of stretching, we can actually cause fibroblasts to come back to the wound site and start laying down even more collagen. We can actually help minimize scarring if the scar is gently stretched up to about the 60-day mark. But if we're excessively stretching or it's being stretched beyond that 60-day mark, then we'll cause something called a keloid. So a keloid is a very large, bulky scar that has excessive amounts of collagen laid due to constant stress or stretching. Keloids are more of an aesthetic problem than a physical impairment problem. Unless it's over a joint and it's impairing movement, it's mostly just something that doesn't look nice. In humans, it's considered a cosmetic issue, but in animals, it might be hidden by the fur anyway, so it doesn't really pose any kind of risk at all for the animal. Another abnormal wound is something called proud flesh. So this is a condition where granulation tissue develops so rapidly that the epithelium cannot keep up with it, and it's a common condition that we see in horses. Certain horses are predisposed to this condition and will have issues with proud flesh forming every time they have a wound. What happens is that the wound starts to produce crazy amounts of granulation tissue within the first 24 to 48 hours. Normal granulation beds take about 3 to 6 days to begin developing, but with proud flesh, it's within 24 to 48 hours. The granulation tissue just starts to build and build on itself, creating this large protruding mass of granulation tissue that the epithelium will never be able to cover, just like the picture of the horse on the slide. There are some factors that might influence the development of proud flesh, such as movement of the wound and tension on the skin around the wound. So we see that mostly in distal extremities of the horse, since the distal joints are the ones that are the most mobile. Also, if the wound is very large, it's more likely that the horse will develop proud flesh. We do have a couple of options for treatment, but we'll discuss that in a future lecture. So we started the healing cycle with hemorrhage, saying that it was good to cleanse contaminants from the wound, but that excessive bleeding was bad. Our body has a pretty intricate system in place to stop hemorrhage and form clots. It's called the clotting cascade or the coagulation cascade. And cascade meaning that it's like a cascade of dominoes. One falling causes another to fall, and so on. To start off, we have tons of different proteins called clotting factors that exist in our blood in an inactive state, but they can be called into action when tissues or blood vessels are damaged. So I have simplified these clotting factors in the next few slides so that you don't get caught up in all the difficult names. I've also streamlined the actual cascade itself, so only the main points are covered and you get a grasp on the process and don't get hung up on the names and all of the different clotting factors. So in order for there to be bleeding, there must be damage done to a blood vessel. When a blood vessel is injured, inactive clotting factors begin to activate. This process is separated into two pathways. We'll go over each one in turn, but know that they usually happen at the same time. The intrinsic pathway is triggered by elements that lie within the blood itself. They're intrinsic to the blood. So damage to the blood vessel wall stimulates the activation of clotting factors by exposing collagen from the vessel wall. Once this occurs, the vasa wall instantly constricts to try to decrease the loss of blood, and factor 12 is activated. Trauma to the blood or stasis of the blood within the vessel can also start the intrinsic pathway as well, so just keep that in mind as you're thinking about the intrinsic pathway. So once factor 12 is activated, this in turn causes platelets from the bloodstream to begin to move to the damaged portion of the vessel, and they will stick together and to begin to form a platelet plug. Factor 12's activation causes the activation of factor 11, which then activates factor 9. And we will pause here, because at the same time that this intrinsic cascade is happening, we have the extrinsic pathway on the left side happening. Now, the extrinsic pathway is triggered by tissue damage outside of the blood vessel, and damage to the tissue stimulates the activation of tissue thromboplastins, which are a tissue protein. And these tissue thromboplastins are released in this huge explosion of release whenever there's any kind of tissue damage from all of the damaged tissue cells. The thromboplastins cause activation of factor 7, which brings us to the portion of the cascade that both the intrinsic and extrinsic pathways share, and it's called the common pathway. The common pathway, factor 7 as well as factor 9, both have to be activated so that factor 10 of the common pathway, the green portion, can be activated. Once factor 10 is activated, it will activate factor 2, and it also will activate a clotting factor whose name is prothrombin into its active form called thrombin. This is a name that you'll hear a lot, prothrombin, and being activated into thrombin, so I chose to use its name instead of its factor number because you will hear it a lot. So after prothrombin has been activated into thrombin, fibrinogen will be activated within the cascade. Another commonly referenced clotting factor, so I used the name instead of the factor number. Once fibrinogen is activated, a fibrin clot will form over the platelet plug that was originally formed at the very beginning of the clotting cascade. One other common clotting factor that's not included in this simplified version is the von Willebrand factor. And von Willebrand is basically the glue that helps the platelets adhere and aggregate in the very, very beginning of the clotting cascade. The coagulation cascade is also dependent on specific vitamins and ions in order to have its factors activate properly. So the following factors are dependent on the presence of vitamin K for their successful activation. And these factors are dependent on calcium ions for their activation. The mechanism of action is not important for you as technicians to know, but just know which factors are dependent on vitamin K and which are dependent on calcium. There are several tests that we can perform to test the clotting cascade. The first is a CBC, or complete blood count. Now, a CBC gives us red blood cell, white blood cell, and platelet counts, and will tell us if we have high levels or low levels. So thrombocytopenia will have an effect on clotting time, as well as if there is an anemia, that might indicate that there is coagulation factor or low platelet counts, allowing for bleeding somewhere, and would definitely warrant further testing for a surgical candidate. The buccal mucosal bleeding time, or BMBT, is a test that can be performed in our vet clinics, and it evaluates the availability of platelets to form a platelet plug at the site of a small cut on the upper lip. The length of time required for the bleeding to stop is measured, and the time can be lengthened by decreased platelet count or by decreased platelet function. So the BMBT is usually reserved for patients that have normal platelet numbers but have questionable platelet function. And this test is performed by making a tiny cut on the inside of the upper lip, and then filter paper is held near but not over the cut And as blood is being wicked away from the wound, we're measuring the amount of time it takes for that wound to actually stop bleeding. Normal time is about 3 to 4 minutes. It's a non-specific test, meaning it's not testing for a specific factor deficiency. It primarily evaluates the intrinsic pathway, will show us platelet defects or deficiencies, or potentially von Willebrand's disease. What do you not want to do during this test? What you don't want to do is actually touch the filter paper over the wound that you've made. You can actually rub away a platelet clot, and you would affect the results that way. And also, if this filter paper looks familiar in the picture, a lot of people use coffee filters. It's just a lint-free filter that will absorb blood. So coffee filters are a very cheap alternative to the special testing kits that you can buy. Our next test is the ACT, which is Activated Clotting Time Test, and this can be performed in a veterinary clinic as well. To perform this test, you need a blood sample that's added to a special ACT tube, which contains diatomaceous earth, which is blown up in this picture on the left, which is basically a special type of particle that will actually activate coagulation factors within the blood. Severe disease in these clotting factors, or a severe decrease in these clotting factors, or severe decrease in the platelet numbers will lead to an increased amount of time it takes for this blood to clot after it's been added to the tube. It's, again, not very sensitive to milder decreases in clotting factors, so it needs to be a pretty severe decrease in these clotting factors. So you just draw the blood, place it into the tube containing the diatomaceous earth, and then the time is measured until clot formation. The normal length of time should be around 75 seconds. Next is PT, or prothrombin time. This measures the functional activity of coagulation factors involved in the extrinsic and common pathways. The PT does this by measuring the amount of time it takes for a fibrin clot to form after calcium and tissue activating factor are added to a blood sample. This is one that can be done in-house. Sometimes it is combined in a profile with APTT, which can be sent off to a lab, or sometimes we have blood machines that have cartridges, like the one in the bottom right-hand picture, that have an APT and a PT combined in the same test that you can run in-house in the veterinary clinic. Activated partial thromboplastin time, or APTT, measures any defects in the intrinsic pathway. A prolonged PT and APTT indicates a defect in the common pathway or multiple defects in both pathways. Usually, it's more common to have the multiple defects in both pathways. This one is usually run, like I said, in a profile with PT, sent away to a laboratory to be done, or sometimes you can purchase the cartridges for your blood machines that you can use in your veterinary hospital. We also have tests that can measure the levels of fibrinogen, which is its own test, but oftentimes if you're sending away an APTT and PT profile, you can add on a fibrinogen assay as well. So this slide just shows you where along the cascade those specific tests are actually assessing what factors, what side of the pathway they are looking at. So we know steroids are good anti-inflammatories, but can be dangerous for healing. Now we're going to talk about NSAIDs, which are non-steroidal anti-inflammatories. I know that you've went over NSAIDs with Christy in pharmacology, so this will just be a brief recap of NSAIDs. NSAIDs are designed to inhibit the function of the cyclooxygenase enzymes that are involved in the synthesis of inflammatory mediators or prostaglandins. There's a COX-1 and a COX-2, and COX-1 is responsible for normal platelet aggregation, GI mucosal protection, and renal perfusion, and COX-2 is the one that's responsible for the inflammatory mediator synthesis. So NSAIDs blocking C2 or COX-2 provide anti-inflammatory and pain-relieving effects, but it's hard to inhibit only COX-2. Usually COX-1 is inhibited as well. So if COX-1 is inhibited, we'll have decreased platelet function, decreased renal perfusion, and decreased gastric mucosal protection. Oftentimes we see ulcers, stomach ulcers, from the use of NSAIDs. And COX-2 inhibition will decrease the inflammation, also might delay GI ulcer healing and fracture healing. So there are positives and negatives to our NSAIDs. So here's a list of some common NSAIDs, and they're color-coded so you can see if they're COX-1 and 2 inhibitors, selective COX-2, or what we call COX-1 sparing, or if they are completely selective COX-2 inhibitors. So the first one is ibuprofen, Motrin, Advil, a common human anti-inflammatory. It is very toxic, renal and hepatic toxicities in our companion animals. It's one of the most common causes of poisoning in our small animal medicine. So not an anti-inflammatory we want to use with our animals. The next group, aspirin, phenylbutazone, which large animal is called bute, ketoprofen, which is ketofin or orudis, and flunexin, which is banamine, another large animal NSAID. These are all COX-1 and COX-2 inhibitors. The next group, etolac, which is etogesic, meloxicam, which is Metacam, daracoxib, which is Daramax, and firocoxib, which is Previcox, are all selective COX-2 inhibitors, which means they minimally inhibit COX-1 or are COX-1 sparing. And then our last one is carprofen, which is Rimadyl, and it is labeled as a selective COX-2 inhibitor. But Rimadyl can actually cause acute hepatotoxicity, especially in Labradors. So although it's safest when it comes to the COX-1, COX-2, there is an added risk of hepatotoxicity. So, which clinical, inexpensive, and fast coagulation diagnostic could and should be done in a preoperative patient known or suspected of having received NSAIDs? This is going to be, in any clinical setting, a test that we can do easily. It would be a buccal mucosal bleeding time test. Would be inexpensive, fast, something we could do in-house to give us an idea if there are any clotting factor issues that we need to test further.